Good afternoon, and welcome to day 4 of the 2023 Within Health Summit. My name is Jamie Singletary, and I am the Director of Clinical Brand Development for Within Health, and I will be your host for this session. Before I turn the session over to my colleague, Dr. Esther Hooley, I do want to go over just some brief housekeeping items for the presentation. We do encourage you to utilize the chat to share any questions, concerns that you may have. I will also be placing my contact information in the chat should you have any complications with getting your CE or CME certificate. Without further ado, I am so thrilled to introduce Dr. Esther Hooley, who will be speaking to you today about Let's Talk About Sex, Sexuality, Considerations, and Eating Disorder Care. Take it over, Esther.
Thanks, Jamie. So typically when people hear that there's going to be a presentation about sex, I usually get really excited because this isn't a topic we talk about too often, or they start to feel kind of immediately uncomfortable. So kind of whichever camp you fall into, or maybe you're somewhere else, I just want to say that I'm very glad that you're here today and really happy to share this information with you. Before I jump in, I do want to go over just a couple of things. One is that I want to let you know throughout this presentation that I am using language that I pulled from research. So some of it might be a bit outdated, and I want to just be mindful that language and terms are constantly evolving. But I did just want to use the language that the research I utilized was using. And I also want to say there are some limitations with this. We have 1 hour today to cover quite a bit of information. And so one of the things I won't be able to cover is the intersection of sexual trauma and eating disorders. So that is just outside the scope of what we'll be going into today. And I wanted to make you aware of that before we get started. So I want to just quickly review the objectives so you know what you're getting yourself into. I'm hoping that by the end of this presentation, you'll be able to name at least 3 ways in which eating disorders and sexuality are connected to one another. I hope that you feel an increased sense of knowledge regarding the link between eating disorders and gender dysphoria. And I hope that you feel like you have a bit of a foundation regarding assessing sexuality concerns. And then the last few minutes of our time together today, I will just be inviting you to explore maybe some potential bias that you might hold, that we might hold related to sexuality. So that's the agenda for today. And we're going to just hop into looking at the connections between eating disorders and sexuality, so specifically where they tend to overlap. So the first area has to do with just both of them being a human drive or a need or a function. But I also want to say kind of, because I want to remember that asexuality, right? That is a true and valid identity. And so some folks may not have a drive or need or function for sexuality the way we might commonly think of it. So I just want to put that caveat out there. In terms of function, we need food to survive individually, and we need sex for survival collectively as a species. So we do need these things for continued life, and both the drive for food and for sex both come from the hypothalamus. So our brain is wired for both of these things. Thinking about abstinence and the abstinence-only model, it doesn't work. That's what we know so far. But when I think of abstinence, I think how sometimes that is language used in addiction or recovery, that to abstain from a substance means that you are recovered, on the right track, all of that. But it gets a little sticky with eating disorders, pretty much because I think about 99% of the time, professionals would agree that food can't be an addiction. Not all the time, but for the most part. And since, typical recovery from addiction requires that full abstinence, we can't abstain from food, right? It's impossible. It leads to great harm. And so it might not fit into an abstinence only model. I also want to say that, there is a lot of research out there that says that abstinence only sex education models do not work, and in many cases are quite harmful. In the sex therapy field, the field that I'm in, experts are also not in agreement about sex being an addiction. I personally don't believe it can be an addiction. Abstinence of sex can be really damaging to a person into a relationship. I do think there can be some compulsive behaviors, but just want to be mindful of that addiction language. And I know for some people, using language like that, talking about a porn addiction or sex addiction or food addiction, is helpful for them in the conceptualization of what's going on. So just a little side note about that. Another way that eating disorders and sexuality are connected is that they both have a focus on the body. So you have to be in your body to be able to listen to cues, hunger cues, to cue into our emotions, and to have a successful, pleasurable sexual experience, however you would define that. We use it to that cue in to know, are we hungry, or are we thirsty, or tired, or aroused? We are constantly checking in with our bodies. But that's not always possible, especially with an eating disorder. And so there's often that separation of the mind and the body. And that makes it really hard to have a meaningful sexual experience if we're not present. So not only can the eating disorder connect us from our bodies, which can in turn impact sexuality, but it also impacts how we cue into our values, intimacy, relationships, life in general. Kind of moving into the connection that it does have on relationships, the thing that I've noticed is that, whether it's eating disorders or sexual dysfunction, it is hardly ever about food, and it's hardly ever about sex, right? Like, that's not the thing we typically work on in therapy. It's, excuse me, all of the emotions underneath those symptoms. So I will do couples counseling, and often there could be a couple coming in. I will likely hear one partner say that their goal for therapy is to have more sex in the relationship. And about 99% of the time, we don't end up focusing on how to have more sex, but we do focus on connection and intimacy and vulnerability, and what enhances that and what decreases that, and the quality of a sexual experience versus the frequency of it. So we're not typically talking just about sex, and same with an eating disorder. We aren't asking too many questions about food, at least as therapists, right? Where we investigate and where we focus is that internal world, and locating where they become disconnected from themselves so that they can reconnect, have a relationship with themselves, have a relationship with other people. We can also look at where eating disorders and sexuality kind of overlap in terms of the areas of pleasure or self-worth. And, I'm sure we are all well aware that those are complicated for those with eating disorders. Typically because disordered eating leads us to believe that, that we have to earn pleasure, whether it's pleasure from food or experiences, and we have to earn rest and fun. So at times then we can have, or I say we, those with eating disorders, can start to believe that they're not deserving of pleasure, and they're not deserving of a relationship, of intimacy, of nourishment. And there is the fear that, what if my body is a burden to other people? And the eating disorder, of course, fuels this belief, and kind of pushes the chance of pleasure further away from a person. I think for some, sex can be a behavior that leads to some resemblance of acceptance of pleasure. So, for instance, someone might think, I don't feel worthy enough, so I'm going to go find some semblance of that, of worth through sexual relationships. Sexual relationships are great, but when, worthiness is involved in that, it definitely becomes more harmful. And those thinking patterns of, I have to earn pleasure, or I'm going to get my worth through what my body could do sexually, these don't lead to greater connection with the self or typically meaningful and intimate sexual experiences. I think with eating disorders, right, we often forget, or our clients often forget, that there's nothing we need to do to earn pleasure or earn rest or to fuel ourselves or enjoy our experiences. We have inherent worth. Our clients are inherently worthy, but the eating disorder is always in there, trying to say that we are not. And I think also how, sexuality might come into this is, when a person with an eating disorder is body focused, right? Or concentrating on appearance or how potentially someone is perceiving them, there's not really the chance for sexual vulnerability. Right? The mind is so focused on the external, or that, anxious thought spiral, that people are unable to be present with their own bodies. And so that can make having a pleasurable sexual experience quite difficult. I also want to note that in both of these areas, there are so many messages, both societal, cultural messages about what is the right kind of sexuality, the right kind of orientation or gender expression, body size, number on the scale. And these sorts of messages really take away from our intuition about what our bodies want and crave and desire when it comes to nourishment and food and sexuality. And so, we can lose a bit of ourselves. And then just overall work with eating disorders, with sexuality, with, work in many areas, just as therapists or providers, we need to be looking at things with, an intersectional lens, right? That we need to remember that concerns are multi-systemic, and we need to have that lens, that people don't just wake up and say, I'm going to start an eating disorder today, and this will be the thing that's best for me, right? But that there are multiple factors that play into the development and sustaining of an eating disorder or sexual dysfunction. All right, I'm going to move into what we see in research. I do want to first start out saying it's been hypothesized that people with eating disorders who are typically emotionally constricted or over controlled, we might see this in like anorexia, that these type of individuals also report limited or constricted sexual functioning, whereas those with more emotion dysregulation, like what we might see with purging or binging behaviors, that there's a lower self-control there, and there's typically more impulsive and chaotic sexual profiles. And so, our sexual behaviors can also align with some of the symptoms that we see in eating disorders. We can also see in research that attitudes about our bodies, of course, impact our sexual experiences. Someone with a healthy attitude towards their own body typically reports, and research shows that they report more frequent sexual experiences, a wider range of sexual activities, and they typically feel more sexually desirable and self-confident. And, the inverse is also true, that the more dissatisfied a person is with their body, the more severe sexual dysfunction typically is or can become. So, how we feel and perceive our bodies greatly impacts our sexual functioning. And I think I also, want to note here that we often see in anorexia a decrease in sex drive, and this is associated with emaciation and hypogonadism. But weight restoration typically helps lead to an increased sex drive. And so as restoration and recovery take place, there is that increase in opportunities for experiencing healthy sexuality. I also want to talk about gender dysphoria and eating disorders. There is so much research about this. And so I want to just, let you all know that I feel like I'm scratching the surface here, but did want to at least comment on this. In both eating disorders and gender dysphoria, there are typically high rates of body dissatisfaction. In eating disorders, that dissatisfaction is rooted in the fear of weight gain or, perceived body fat. And in gender dysphoria, it's typically rooted on secondary sex characteristics that are discordant with a person's gender identity. I think it's interesting, trans folk typically have higher rates of dissatisfaction with body parts that are not sex specific, so such as facial features or body shape. And I also think when we, think of just sexual minority adults overall, we've got a pretty recent study done in the United States that show that adults who identify as being a sexual minority have a 2 to 4 times greater odds of experiencing a DSM-5 eating disorder diagnosis, just compared to cisgender hetero adults. So there is a higher risk of eating disorders linked to being a sexual minority or having a sexual minority status. And I think that makes a lot of sense, when that felt or internal sense of gender doesn't align with, the gender a body may represent or how it's perceived. Of course, there would be higher levels of distress because we're being missed. We're not being seen for who we are. And that increased risk of body dissatisfaction, right, where gender and presentation are not authentically aligned, that clues us into that higher likelihood of eating disorder behaviors. And with teens, when there's disruption in the development of gender and sexual identities and negative body image, this typically leads to reduced levels of sexual well-being. And when sexual well-being is impacted, overall well-being is typically impacted. So it's something to remember, like that this starts and can start quite young. I also wanted to talk about a few places where gender dysphoria and eating disorders interact. So specifically how eating disorders could mitigate or intensify gender identity distress. And through investigating trans non-binary individuals' understanding of the connectedness between gender and eating and body image concerns, research has really showed us that there are a few areas that are really important in conceptualizing eating disorders. And that's the areas of gender congruence, puberty, emotion regulation, gender expression, and recovery transition. So I want to dive into these just a little bit. Again, we are just scratching the surface today, but do want to provide a bit of information. So with gender congruence, we often, or we can see the function of the eating disorder to be connected to punishment. So for example, someone experiencing gender incongruence could use the eating disorder to punish their bodies for not being what they want and a way to punish themselves for who they are. the distress becomes so great that the eating disorder kind of functions as this reminder of the pain of gender incongruence. And so that might sound like someone saying, my body is too feminine in appearance. So, we might use the term curvy. That's what the research used, which isn't my favorite, but we're going to use it. And so, my body is too feminine in appearance. So I'm going to restrict my intake and change my body shape to create a sense of gender congruence. So that's how one way that an eating disorder can function. Also, in terms of puberty, eating disorders can be used as a means to stop puberty. This can, aid in avoiding any body changes that could be read as gendered, and is often a way that an adolescent or young person can regain a sense of control over a body that they might feel has betrayed them. And so this might, look like someone saying, I can't control how my body presents. I control some, but not all the way. And I can control whether I care for it or support its growth. Eating disorders can also be used to regulate emotions, especially when it comes to gender dysphoria, all of that distress we've mentioned. The thought along this line might be, if I pour my effort and energy into an eating disorder, right, a really great distraction, I don't have much time to focus on my gender. So I will regulate my heightened emotional distress by leaning into this eating disorder as a coping skill. And sometimes that's, conscious, and sometimes that's unconscious, but can be possible. When it comes to gender expression, we've talked a little bit about this already, but the eating disorder is used to meet social standards regarding what is typically seen as or described as feminine or masculine or androgynous. And the eating disorder supports obtaining a gender expression that is culturally expected. So, women are thin, so to be a real woman, I must make my body a certain way. And so it's used to try to align and meet those messages, those societal and cultural messages about what a body looks like, and what a certain gendered body should look like. And then also there's the piece of recovery in transition. So as a person's gender potentially becomes more congruent, through the transition process, hormone replacement therapy, surgery, whatever it may be, there tends to be this thought that the more accepting I become with my gender, then the further away the eating disorder gets. And the function of the eating disorder is no longer needed. And that can happen both, obviously, in the recovery process, but also in the transition process as well. I do want to make a note here about gender affirming care in eating disorders. Trans folk face so many significant stressors, discrimination, barriers to accessing healthcare, there's peer victimization, violence, family rejection, maltreatment, and typically trans folk are underinsured relative to cisgender people. So you take all of these stressors and you couple it with all of the legislation that's happening, right? Like this year alone, there's been 576 bills proposed related to the restriction of care and access for, trans non-binary folk across 49 states, with 83 of them passing. So you take all these stressors, you take legislation that we know is meant to keep healthcare from certain people. I mean, we're essentially just priming a whole group of people for mental health concerns. So gender affirming care is incredibly important when we're working in eating disorders. One of the reasons is research kind of points that if gender affirming medical care remains inaccessible, that these folks might resort to eating disorder behaviors to manage their gender dysphoria. Therefore, creating this maybe high increase of eating disorder patients. So I want to encourage all of you to maybe just take a moment and think about, you don't have to put this in the chat, just want you to think about it. Think about how you're providing gender affirming care, like in whatever capacity it is that you work with your patients. And while you're doing that, I want to share maybe just a few things that come to mind. This might feel foundational in a way, but gender affirming care can look as simple as using a person's correct pronouns or their preferred name. It looks like introducing your own pronouns, when you share who you are. And if you have a brick and mortar office, how is it set up? Could someone look around your room and know that you are someone who is safe for them and you are a provider they can open up to? Like, these are just a couple of things we want to be mindful of. And I think also there's the opportunity for us as providers to be very conscious about our language and moving towards a more, gender neutral language repertoire. So that might mean we're very intentional about using words like siblings instead of brother or sister, or partner instead of husband and wife, or boyfriend or girlfriend, and that we don't guess someone's gender based on their appearance, and we stop saying things like you guys and you ladies and instead say you folks, to be inclusive. And people pick up on language, and so it's just one of the ways we can be very intentional about providing the care we want to be giving to our patients. Want to move into assessment here, and I am very aware that sometimes we can struggle as providers to know where to start with an assessment of sexual concerns. I say that because I went to years of graduate school and I had one human sexuality class, and never once did we talk about assessment. So there's typically just a lack of training around sexuality that happens. And so a lot of this I've learned because I'm working on my sex therapy certification. But if I wasn't, I don't think I would know this information, like not off the top of my head anyways. So I want to pass along a few options for gathering information about sexuality. So the first one is called the 6 Ps. And these are guidelines based on CDC recommendations for a sexual health assessment. As you can see, they all start with the letter P. So the first one is partners. So we would want to ask, the number and gender of partners, nature of relationships with these partners. And again, this is a space where we remember to not make assumptions about the gender of your client or the identity of their partner or partners. So we just want to be mindful of language as we do that. We want to inquire about practices. What kind of sexual contact do you have? What parts of your body are involved when you have sex? Are you a sex worker? What aids are typically used? Is there substance use involved in your sexual experiences? So we want to get a pretty general idea of what happens during someone's sexual experiences. We do want to ask about protection. Do you and your partner or partners discuss STI protection? We would want to inquire about what methods are used and how often, if there are preventative measures for STIs and HIV being used, and then any current or past strategies for protection. We also want to inquire about a past history, specifically because we do want to be very mindful of STIs, kind of what, when, how it was treated, how often do you get tested. But we also, this is really the area where we would ask about, consent violations, trauma, assault, And of course, this is nuanced because it is more sensitive information, but I just want to give it to you as part of the assessment process. And then we also want to inquire about pregnancy. And we want to explore this without assumptions. We want to discuss birth control as appropriate. We want to assess for abortions or miscarriages, explore any family planning desires. And this is also an area where we remember that people who present as typically male can still have a history of pregnancy. And so we do want to not make assumptions when we're in this category here. And then we also need to know about pleasure. Are you satisfied with your sex life right now? Are you and your partner or partners on the same page when it comes to desire and boundaries? Are there difficulties or problems when you have sex, like pain or desire discrepancy? So doing this, I mean, this could take an entire session to do. So this is often what I would encourage like a therapist to do typically. And then the next option we have is these kind of 4 opening questions. And these are typically used more in the medical field. And you can, they can be pretty simple, but you can open them up if you need to. So you would want to first inquire about the satisfaction with the quality of sexual life that a person has. Or you might then add on what would make it better, or in what ways are you not satisfied? You would want to know if there were sexual problems or worries that they would like to discuss. You can just, open that up with, do you want to discuss sexuality with me today? And, I say this is so important because I was thinking back to my own experiences as I was putting this together. And I've never had a PCP inquire about my sexual health. It has only come up in a very, very limited way with an OBGYN. And so it's really important that as providers, we are asking about sexuality or not. And I think one of the reasons maybe it's missed sometimes is because people, believe it or not, still consider talking about sex as it's a taboo thing. But if you're the provider and you're bringing it up, it really takes the burden off of the patient or client in front of you. And it signals to them that, hey, you have permission to talk about this, and I'm okay to talk about this with you. And so you take the obligation off of your patient to bring it up by you bringing it up first. You could also inquire about influences. So by that, I mean, are there medications or medical conditions that are impacting sexual functioning? So you might say something like, sometimes people who suffer from hypertension or who are on SSRIs have sexual issues. Are there any concerns you want to share with me today? And then you want to know severity. How much is this thing that's going on bothering you? Or how does it impact your life, your relationships, your sense of self? So those are just kind of 4 areas. There's not specific wording for them, but that's kind of your very quick sexual assessment. And then I would also think about using the sexual ecosystem approach. This is something that I think if like you're, one of your passion areas, or you're a sex therapist, whoever it may be, like if you really want to sit down and get into it, you could use this systems approach. So you would inquire about microsystems. So that would be like the development of early childhood, developmental experiences and family of origin, biological issues, that sort of thing. You would inquire about the next stage mesosystems is about relationships that you've had in late adolescence or adulthood. Typically, those have more sexual influence in them. We would look at exosystems, which is just the indirect influence from other systems onto sexuality. So some examples of that could be like religious systems or healthcare systems. And then, kind of our last level here is looking at things on this macro level. So what are the sociocultural influences on sexuality, right? What are your attitudes about sex and gender, and how are they formed? And so this really takes a kind of deeper dive into the history of a person. And of course, it's for gathering sexual health information, but these can really expand into a lot of other areas and give you information about mental health. One thing I want to say in kind of any of these scenarios that you might use is that it's incredibly important to be curious versus pathologizing any behavior. So, there will be biases that will come up for you. We all have biases, and we definitely hold them about sexuality. And this can lead us to stereotype. One example of this, the one I hear most commonly, is that, if you're someone who's involved, or you have a client who's involved in BDSM or kink, it's because you've had a sexually traumatic experience. And, research really doesn't support that. It's debunked that. I think, 50 Shades of Grey kind of gave that myth a revival, but, we don't have anything substantial to support that stereotype. And so it's something to just be mindful of and to remember, like, I'm here to learn about this person in front of me, and I have to start from a place of curiosity. I also want to think about maybe some more eating disorder specialized assessment when it comes to sexuality. And this is important because we do have empirical evidence that demonstrates that, the evaluation of sexuality is fundamental to obtaining a more precise characterization of the severity and prognosis of eating disorders. A more severe compromise of sexual health, both in terms of dysfunction or risky behaviors, can often represent a more severe eating disorder. So we do get information, and that's why it's important to inquire about these things. So one that we'd want to look at is reactions during sexual experiences that a person might have. And this helps us obtain some useful information related to potentially the trajectory. An accurate evaluation of sexuality might reveal that some patients report dissociative experiences during sexual activity or stimulation, or only during certain sexual acts, as well as we would gather information about like spectating, which is the act of observing yourself as a third person when you're involved in a sexual activity. And research has really shown that there's a strong relationship between these phenomena and the history of sexual abuse. So an accurate assessment of features, of what happens, what are your reactions during sexual experiences, gives us hints about the development, or could give us hints about the development of the eating disorder. We also want to know about risky sexual behaviors, including promiscuity, although this description, or even assessing for that is kind of culturally dependent. So we want to be mindful of that. But we would want to know about hypersexual behaviors because these might suggest, again, the presence of previous traumatic sexual experiences, which we know is highly correlated with an eating disorder. And risky sexual behaviors often speak to anxious attachment. So, it does give us information regarding attachment patterns, and assessing risky sexuality, I think, helps with also adequate treatment planning. Because, we learn about maybe potentially traumatic childhood events and attachment insecurity, and we can adapt our interventions to address these attachment needs rather than having it focus just on an eating disorder, right? Like we can look at emotion regulation and dysfunctional interpersonal patterns and put that into our treatment planning. And we, of course, want to assess body image, right? A person with severe body image distortion might also show severe dietary restraint, which is often associated with anorgasmia, or the inability to orgasm, or low sexual desire. Interpersonal connectedness is also important in determining healthy sexuality, and dysfunctional patterns of sexual activity, because these may represent just a severely damaged capacity to create bonds with other people. And I think also, when it comes to body image, which we have already talked, impacts sexual health and sexual functioning. Research suggests that worse sexual functioning at baseline is associated with worse long-term prognosis of the eating disorder. Also, when we look at pleasure and reward, we talked a little bit about this, how there's maybe this sense that we have to earn this at times, or those with eating disorders have to earn it. But part of healthy sexuality is having our reward mechanisms functioning properly. So both sexual and eating behaviors are associated with dopaminergic circuits in our brain, right? So in particular, starvation, binging, purging, those have all been conceptualized as reward-driven behaviors. So when eating disorder behaviors are sustained, right, there's an alteration that happens in those circuits. And due to this alteration, pathological eating behaviors, whether that's like restricting or excessive physical activity, so those behaviors and food-related cues really become the only salient stimuli. And so anything that used to be kind of typically rewarding loses its saliency, and the severity of the compromise of sexuality might hint at the extent of the damage of reward systems. So we can look at what does pleasure and reward look like in your sex life or sexual behaviors, and how does that inform what it looks like in your eating disorder. We also want to assess for the severity of the compromise of sexuality. So when we look at someone's sexual dysfunction and gain clarity regarding the severity of it, this can provide us with information about how a person is either able or unable to experience reward and pleasure. And the severity of the sexual dysfunction, often this can be associated with great distress or mental pain, depressive symptoms, relational isolation, all of which we see in the maintenance of eating disorders, right? So it's important to know as it creates a better understanding of the overall understanding of patient functioning. So I hope you can see, it's a little, kind of clunky at times, but information about sexuality really helps us understand eating disorders, and it can. And I think often this is maybe left out of our assessment phases, but is something for us to continue to think about. I want to transition now, kind of moving away from information, more towards the provider side of things. So we, of course, have significant impact on our clients, right? Beginning from the very first time we meet them. And as I was saying a few minutes ago, we model what can be talked about in session. And of course, we know kind of everything can, but often clients are looking to us to give them permission about what we can talk about or not talk about, right? And what we say or don't say can often communicate quite a bit about our own comfort or discomfort with certain topics. So I wanted to read this statement to you, and the bolded, language here is mine. I added that. But many physicians still avoid speaking about sex with their patients because of shame, or the general belief that sexuality and sexual dysfunctions should be considered as secondary with respect to the other severe complications of eating disorders, including medical and psychological ones. However, empirical evidence suggests that assessing the sexual health of a patient with eating disorders can be useful. So I wanted to highlight that, it's our own stuff that might get in the way of us talking about sexuality. It could be something as deeply rooted as shame, or just maybe the biases and beliefs we hold about the importance of sexuality or sexual dysfunction in the life of a person. There are also other factors, I think, that I'd love to maybe at the end of this hear from you all what might be keeping you holding back in sessions. But, we have things like personal discomfort, right? Some of us just grew up in families or cultures where, talking about sex was just unheard of. and it was uncomfortable. And we never really learned how to do that well and in an authentic manner. And, our own stuff follows us into the therapy room or into the patient room. There's also can be a lack of training, which is quite common. I think I mentioned, I was in grad school for 8 years and one human sexuality course, which is such a disservice. But often, we do have to go seek out this information on our own. I think for some providers, there can often be the fear of crossing boundaries. Whether that actually happens or not, this sex is just such like a no topic to talk about in therapy. And I think we might have this worry, or some of us have this worry of what if it leads to something else, right? What if I find myself attracted to my client or aroused or whatever it may be? And so it's our anxiety then that holds us back. And that's a great time to seek some consultation or supervision, even if needed. And then, of course, our own biases and stereotypes. So I don't know if y'all have heard this saying or not, but if we're breathing, we're biased. So I think it's really important that we recognize we all hold this within ourselves and be willing to face it and explore it. And I want to give a couple examples of what bias could look like. There's a really wonderful article I would just highly recommend reading called Let's Talk About Sex, Integrating Sex Positivity in Counseling Psychology Practice. I really like it because it focuses very much on the provider knowing their own biases and the impact of this on client care. And it provides a list of, I wouldn't know if I would say common biases, but many examples of biases on the intersection of diverse identities and sexuality. So I wanted to give a few examples here and just kind of ask that you notice what comes up for you. Or if it's like, oh, wow, this is actually something I do think, because I had that reaction reading this article. Just why I'm encouraging you to maybe go look at the whole thing. But one of the questions is, do I consider clients with physical disabilities sexual beings? So, right, this kind of pulls on our potential ableism that might be there. Do I assume that younger males are oversexed or sexually preoccupied? Or gender stereotyping can come out there. Have I assumed people who engage in BDSM have an underlying pathology that explains their behavior? Right? So we might over-pathologize to make ourselves feel more comfortable even. And do I assume that transgender clients will be unable to find and keep a romantic partner? Right. So our heteronormativity bias can show up. And so these are types of questions. And again, these are just a couple examples that if they go unanswered or avoided, it really impacts who we are with our clients and how we're able to truly connect with them and make them feel safe. Kind of lastly here, I want to give us a moment to reflect on the impact of who we are when we provide care. So I put these questions up here. I'm going to read them to you. What parts of you contribute to avoidance? So avoidance of talking about sexuality, addressing sexuality in therapy, and this could be your story or personal fears or education and training, or, what part of your background do you think is maybe contributing to the barrier? And then how does this avoidance impact interactions in therapy or clinical work or supervision or case consultation, right? Are we leaving parts of, a client's story out, and why are we doing that? I think also, of course, need to ask, what are some of the assumptions and biases that I hold or you hold regarding sexuality? And so there's a clue. If we say we have none, it means we probably need to dive a little deeper. So I want to, really ask that you be curious with a question like this. And then lastly here, does your intake, your biopsychosocial assessment, your initial assessments, treatment goal planning, do all of these, forms, paperwork within, your company or office, do they think that sexuality is important? Are those pieces about sexual health or sexual history, or even like, hey, is there a sexual concern? Do these show up in your paperwork? Because that's a reflection on what we think about sexuality and how much we value it. So I want to give everyone maybe just about 2 or 3 minutes, and I ask that you maybe bullet point some thoughts that come to mind, as you answer these questions. And then Jamie's going to come back on, and if you're feeling brave enough, I would love for you to maybe share some answers or even things coming up for you in the chat so that she can read them out. So they will be, anonymously shared. Only Jamie sees that. And if nothing comes up, I also want to be able to leave a few minutes for questions. So I'm going to leave these up here for a bit and give you all a chance to do some exploring.
Esther, I will share while they are thinking about what to put in the chat. We did have a comment that spoke to hypersexuality being also related to manic episodes for bipolar.
Yeah, absolutely. Yeah, thank you for that comment.
There is another comment here, wondering how much should go in the electronic health record in the hospital.
Ooh, I do not work in a hospital, so I am not quite sure, but I think, you might be able to use those 6P questions, those 6Ps to put, some very minimal, whatever's clinically relevant. And so again, we don't want to pile a chart full of information. We want to be mindful of what needs to be shared about the client. But I would see using that as a framework might be beneficial.
The attendee also mentions that insurance has access, patients have access to read all the notes as well.
Mm-hmm. Yep, they do. That's why we're mindful of our language and biases.
Okay, we have a question. It says, I think of myself as very open to sexuality. However, my intake BPS doesn't identify that. I have to think about why and how to best introduce it. What are best ways to open this door if it is not related to the presenting concern?
Yeah, I mean, I think it has a lot to do with framing. And so paperwork might mention just how sexuality is one piece of identity of sexual health, mental health, emotional health, physical health. This is just one piece of the puzzle. And so framing it as normative and typical to be inquiring about this might be a way to frame it. Also, it can be pretty broad. What do you want to tell me today about your sexual health or sexual history? People will definitely say, I'm not telling you if they don't want to tell you. And so I think we can trust the client to also be able to navigate, in some instances, what are the boundaries of this and what does this provider need to know?
Here's another question. It says, I can relate to the bias of thinking of sexuality as a secondary to other eating disorder concerns. Sometimes it feels like there is just so much to focus on. So how would we intertwine the sexual component as a priority?
Yeah. Oh, I love that question. I'm thinking of a case, and more recent case actually, and we've been talking about sexuality a lot, actually, myself and this client, and we've been talking about it in the context of desire and pleasure, because those pieces have been impacted by an eating disorder, by trauma, by interpersonal wounds, and definitely shows up in the sexual relationship this person has with their partner. And so kind of using that language is the way that we always end up there, whether it's specifically about sex or just in those themes of pleasure and desire. I don't know if that answered your question. I hope it did, but I can also expand on that if needed.
We do have another question. They are actually blowing up in the chat, Esther. This is amazing. This particular attendee wants to know, when you were speaking about intimacy versus sex with your couples that you work with, is there any language that you use to help differentiate between the two?
Mm-hmm. Yeah. So one thing I do is actually ask my clients to define that with me because it's different for everybody. And then I can provide some education. So, excuse me, I've got a little tickle in my throat. I frame intimacy, like sexual intimacy, physical intimacy, as one piece of the pie. And, when I'm talking about the development of a relationship with someone, how did you meet? What drew you to this person? People don't typically say it was the amount of sex that we had. So, I remind them that, like, hey, that's one piece of the relationship, but look at all of these other ways that you all have grown and been intimate with one another. And where are the ways you see, or where are the areas you see vulnerability showing up besides sexuality? Because vulnerability hints at intimacy. And so that's one of the ways I might explain it. But I really am always interested in hearing how my clients explain it because it's very telling just about their own background and expectations in the relationship that they're in.
Here's another question from an attendee. They want to know, as it pertains to sex in the session, you mentioned shame, you mentioned boundaries, and as providers feeling uncomfortable. Are there any books or webinars that you can suggest that can help dispel some of those stereotypes around that?
Yeah, this is going to be awkward, but I'm looking at my bookshelf here really quick. Can I show it up to the camera?
Sure. It looks like you're reaching into the mountain.
Yay. No. So can you see it? No. Nope. Okay. It's called A Clinician's Guide to Systemic Sex Therapy. I found this book incredibly helpful. There's tons of assessment information in it. But it also helps the clinician explore their own reactions so that they can help their clients explore reactions. And so I just found this book quite incredible and freeing and informative and helping me decide how I want to do assessments with my sex therapy clients. So highly recommend this. It's A Clinician's Guide to Systemic Sex Therapy, and it's the 3rd edition.
And who is the author?
Gambeskia, Weeks, and Hertlein.
All right, it looks like we have time for 1 or 2 more questions. This particular question is asking, as it pertains to ethics around clients and feelings and emotions that could potentially arise in a session if talking about sexual desires, how do you handle that, or what would you suggest if that were to come up in a session?
Yeah, I mean, I think we can pretty easily pick up on nonverbals as providers. And so I'm really mindful of what someone's body language is saying. And honestly, whether I see some amount of discomfort or anxiety, I pretty much guess that everyone's feeling that when I'm asking them questions. And so I will often check in, like, what's coming up for you? You just said this word, and that's probably not a word you go around saying. Like, how did it feel? What was it like to share it with me? So just kind of talking about the process of what's happening, what's coming up for them, normalize, or say, you look really uncomfortable saying this. Like, is there a different word you want to use? Or is there another way you want to talk about this? Because sometimes, clients really respond to metaphors even. And that can be, delay some of the anxiety, but also keep the person centered and on topic, on focus.
And our last question, do you feel that the rise of social media and different social platforms have increased our sexual knowledge or desires, or does that play a part, you think, in how we view sex?
I don't have any research to pull into this moment, but I would guess yes, because, we are influenced by everything. And there are so many messages, positive and negative or neutral, that show up in social media. So, I can't say what is the direct impact, but I would say, of course, we're impacted by it. Sometimes for the better, people are more open and willing to explore. And sometimes, not for the better. There are a lot of myths that are thrown around and disinformation. So kind of either side of that, I would say, yes, we are, greatly impacted by what's going around in social media as it relates to sexuality.
Thank you so much, Esther. This was an amazing presentation. You are getting a lot of praise in the chat. People saying thank you very much. It was extremely interesting and a very important component of the work that we do. So with that being said, thank you all for taking the time to join us in this presentation. And I hope that you're enjoying the summit. And we will have one more presentation today, and that will wrap up the Within Summit 2023. Thank you and have a wonderful day. Bye.